Welcome to today's webinar on 3 pounds of matter injured. Now what? Long-term considerations for medical legal cases involving traumatic brain injuries. This is part 2 of a webinar that was previously recorded where our host will dive into some case studies. We're excited that you've joined us today. My name is Gigi Liggins and I'm the moderator. Our presenter for this webinar is Cynthia Borbo. Cynthia Borbo is president and founder of Medical and Life Care Consulting Services and has worked as a Massachusetts registered nurse, certified rehabilitation nurse, certified nurse case manager, and certified nurse life care planner for over 4 decades. Founded in 2001, MLCC provides life care planning, Medicare set-asides, legal nurse consulting, and more throughout the United States and internationally. MLCC also provides case management services throughout the Northeast region of the United States and a wide range of care consultation for catastrophic injuries. Cynthia is a member of the Association of Rehabilitation Nurses, the American Association of Nurse Life Care Planners, the International Association of Rehab Partners, and the Case Management Society of America. She is also a board member of the Certified Nurse Life Care Planner Certification Board. At this time, I'll pass it over to Cynthia to proceed with this webinar.
Hello, and thank you for joining us today. As we discussed, this is the second part. The first part 1 was quite lengthy, so we split it into 2 presentations. The objectives of this is really to give you a better understanding of long-term requirements for care and equipment for various types of brain injury. And so 2 case scenarios will be reviewed, and so that you can understand what those different needs are between a mild head injury and a severe TBI. So again, I want to remind everyone that every patient is different. Everyone has a different medical history and background. And so every single life care plan is unique. This is just a collection of treatments, and none of the cases are actual cases that have occurred or are occurring, but are a combination of multiple scenarios. So the next few slides are a review of what was part of what was presented in the last presentation. I'm just including them in this talk so that you can actually refer to it easily. But please feel free to go back to the original and get all the description that goes with it, as these are just explanations, definitions. Traumatic brain injury happens when a sudden external physical assault damages the brain. And it's a broad term that describes a vast array of injuries that can happen to the brain. They can be in one area of the brain or multiple areas. So we're going to be reviewing a mild concussion and then a more severe injury that can result in coma or death. And so the different types of TBI are closed brain injury, penetrating brain injury. I'm not going to define them again. You can look back to the last presentation. And the same with diffuse axonal injury and the injury that isn't always visible by CT or MRI, microscopic tearing in the brain's connecting fibers or the axons. Next. So these are all the possible results of brain injury in every type, in every area of our life, in our bodily function. So cognitive, motor, perceptual, communication, functional, social, regulatory disturbances, personality disturbances, traumatic epilepsy. And again, just to reiterate, when I'm working on this, I'm assuming that everyone has a background in life care planning and knows what a life care plan is. So a life care plan is a plan for the patient that outlines all the medical and non-medical needs that patient will need for the remainder of their life, and also the costs associated with it. And these are the different types of treatments. And so the next few slides are just how a life care plan can break down. So we're just going to scroll through those, but you will have these in the presentation so you can look at them in detail. This again was included in the first presentation. So next, and go ahead and keep scrolling through. Keep going. And there you see all the different areas that we're evaluating patients' needs as. So all of these different areas can be included in a life care plan. So let's see, our first case study is a mild concussion. So this first case study is of a 64-year-old female. Mrs. Ronald was a 64-year-old white female who was self-employed at the time of her injury, doing billing and coding out of her home. She had 2 children, a boy and a girl who are grown and living in their own homes. So she lives alone in a single-family 2-story home. Miss Ronald slipped and fell and struck her head. At the time of her fall, her head bounced off the ground, hitting the ground twice consecutively. Initially, she had frequent headaches. She reported a pain level of 4 to 6 out of 10 at rest, a 7 to 8 out of 10 with activities, with any computer work, and with transfers. She had multiple trigger points in the upper trapezius and lumbar spine, which improved with manual therapy. She had an occipital nerve block to address persistent headaches without benefit. She has trial gabapentin, ibuprofen, and magnesium. Her headaches have improved. However, she continues to report headaches 1 to 2 times a week. She is not currently taking any medications for her headaches, but will nap if she is able to instead. Her physician indicated her headaches are cervicogenic in nature, and she will most likely need additional treatment for diagnostic and therapeutic purposes. Symptoms she reported immediately following the fall were poor concentration, frequently losing her train of thought. She took only 2 weeks off from work and then gradually returned. She wasn't able to concentrate for long without having to take a break, however. But by 3 months post, she was about at 3/4 of her full-time schedule. But she found it was taking her longer to type and to read. She reported some mild inattention in conversation. Since the time of her injury, she has experienced photophobia. Initially, this was significant and she wasn't able to tolerate light in or outside of her home. With time, this improved. However, she continued to report this problem ongoing when she's outside, and she wears sunglasses to manage it. She's also experienced phonophobia. This has improved with time. However, she continues to report decreased tolerance to loud noises. In addition, she has had dizziness and poor coordination. She felt unsteady as if she were going to fall. She completed vestibular therapy, which offered some improvement in her balance, but she continues to report unsteadiness. When ambulating, she reports that she feels that to maintain her balance, she has to sidestep on occasion. She is ambulating independently and has not fallen. It was noted that she was unable to carry out her ADLs and IDALs due to post-concussive syndrome. She was having trouble with changing positions, doing any vacuuming, cleaning, dusting, washing overhead, driving, lifting from the floor, lifting overhead, and transferring in and out of her chair. She would have imbalance issues when this occurs. She did report that she progressed and she felt she did better and was doing better now, but she indicated that she also felt that stress made her symptoms worse. She responded well to manual treatment, and balanced techniques were added to her treatment plan with improvement of her symptoms. By August, she had improvement with her ability to clean, dust, and wash overhead. So now we're going to go into the actual life care plan. And so obviously we do projected evaluations. So any treatment that is therapeutic an evaluation is done first, and then treatment is put in place afterwards. So with physical therapy, exacerbations and complications, I didn't feel when I saw her that she had reached her maximum medical improvement. And so consequently, I did put some therapy in place. I'm going to show you here that physical therapy, evaluations, complications, and exacerbations, and then physical therapy, vestibular therapy, which is different. Both those evaluations were recommended 8 per her lifetime. And you can see, if you look at this, I'll show you one of these tables, explain one of these tables. So it shows the actual item service, the age that the treatment is started, the age it ends, the purpose for it, the schedule, how many per lifetime, and then the base cost, the annual cost, and the lifetime cost, and then what resources were used to provide it. Obviously, this was some years ago, so costs were less then. So then we go into projected therapeutic modalities, which is the next section. And here it shows how much treatment. So, and this, we see that she had, a whiplash injury when she slipped and fell, resulting in neck pain. And physical therapy for manual techniques were effective in improving her symptoms. But she is at risk for exacerbations and periodic treatment because her symptoms have not totally resolved. So it's not always easy to identify how frequent people are going to have exacerbations and complications. So patients can have them once a year, they could have them 3 times a year, they could have them once every 10 years. In my practice as nurse case manager and rehabilitation nurse, I see patients throughout their lifetime, the same patients. So I've done outcomes on this, and I find that really every 4 to 5 years with an underlying problem like this, people come back and need treatment. So because of that, this is what I chose to put in the plan. Basically, she potentially will have a complication or an aggravation every 5 years, but it could be longer than that. And that evaluation is also determined by the patient's medical history and what she's done for treatment to date. So future medical treatment are the physicians that she will see. And so this is a list of all the physicians that she would see and how often those physicians are recommending treatment or has been recommended for treatment. So neurologist, when I evaluated the patient, I felt like she was still in a semi-acute treatment pattern. And so she was put in with her neurologist twice a year for 2 years while she continues to treat. And then that will decrease after that. She'll just see a neurologist for complications and exacerbations. 4 exacerbations in her lifetime. Miss Ronald suffered a concussion when she fell, and as demonstrated by those post-concussive symptoms, her doctor indicated that she continued to have cognitive issues and wasn't able to concentrate for long without having to take a break. And it's not clearly documented if these symptoms have resolved. So a neuropsych evaluation was recommended. So I put 1 in her lifetime. Ophthalmology, she had issues with her vision as a result of her concussion. Routine eye exams are recommended by her treating physician as her vision issues have continued. Prior to this injury, she had no pre-existing vision issues. And so these evaluations are put in once a year. Physiatry is another area of another physician that would treat her. She's being treated for whiplash injury, and it was identified that she has persistent headaches that may be cervicogenic in nature, and an evaluation by a physiatrist to address additional treatment options such as injections is recommended. And so for the next 2 years, while she's in this still acute treatment time period, 12 visits for evaluation and then for treatment. After that time, she will only see the physiatrist in the event that she has an exacerbation of her symptoms. So those number of visits have been included in her plan. Her primary care physician has been overseeing her care. And in the future, what will end up happening is her first visit will be with her primary care physician, which will be the gatekeeper. And then after that, she'll be referred to the specialist. So adequate visits were put in to deal with the potential exacerbations that she's going to have. Now, I also put in here psychiatry, and Miss Ronald has a history of depression, and she's been seeing a psychiatrist to manage this since the age of 26. The medical records indicate that she's seen twice a year, but she's had an increase in depression and anxiety post this injury. And so ongoing visits were recommended by her treating physician. But as she was back to her pre-injury status, she does need to see the psychiatrist twice a year, but there's no cost to this plan and to this injury. However, let's see, do we have anything else? I think I got it all. Okay, next is diagnostic testing and lab work. So again, I identify everything that the patient may need for health, because that's the goal of the life care plan, is optimum health. So she has a history of pernicious anemia, so she's going to have routine blood work to monitor her blood levels. Those should be done once a year, and for both her CBC, there's no cost to plan. In addition, she has hypothyroidism, so she'll have yearly routine blood work for that, but there is no cost to plan because it's not related to this injury. Regards to MRI of the brain, with her post-concussive symptoms, if the symptoms were to worsen, repeat testing would be indicated to evaluate for changes. So 1 per exacerbation, 4 exacerbations in her lifetime. In addition, she has cervicogenic symptoms, so treatment will be focused on that area with therapy. But if her symptoms exacerbate, then they're going to want to get an MRI, so treatment is put in place. So these are just samples of types of treatments that could be identified in a mild injury. Next. Durable medical equipment. So she's very functional, but she does have some impairment that she needs support for. So that would be a cane. That would be one every 10 years. She is not using it regularly. So I just started it at age 75 to 85, one every 5 years. She's using a cervical pillow to help with her neck and head pain, and that is replaced every 2 years. Grab bars 2 times in her lifetime. She has some unsteadiness and instability. So for correct and safe showering, we want to make sure that she has that, and also a handheld shower, 2 per lifetime. With her continued photophobia and sensitivity to light, I provided sunglasses every 2 years, although it seems like people lose them 3 times a year at least in the summer. But obviously we're just dealing with what she needs for her injury. So every 2 years is adequate. And then a shower bench for personal care again, and her instability. And then as she ages at age 75, I would provide a walker from 75 to 85, because that unsteadiness that she has will just get worse as she ages, if it doesn't resolve completely now, which it has not. Medications is the next section. These are pretty straightforward. I base medications on what the patient is actually treating at the time of the life care plan is completed, with the anticipation that they will, unless it's specifically identified that they will only be using it for a certain period of time. I anticipate that some type of medication like what they're taking will be used, even though not specifically that medication. So each medication that has been approved as part of the life care plan, some form of that type of medication will be used in their future. So the first is amitriptyline, and that was to help with her headache pain, and one prescription per month of 30 pills or 31 pills, and the costs are all there. She was on Crestor prior to the injury. She was on lorazepam prior to the injury, and she was on sertraline prior to the injury. So those were all continued. However, she was on them prior to the injury, so there's no cost to plan. And then for her head injury, magnesium 400 milligrams was ordered by her physician, and she is to continue that indefinitely. Next page. And then surgical and medical procedures. So just prior to the life care plan being completed, this patient was offered cervical facet injections, and those were going to be done. So I did include 3 per year. And also cervical for facet injections for future problems from that cervicogenic pain. So 3 injections per exacerbation, with 4 exacerbations in her lifetime. Okay, so that is a mild head injury. Now, again, there are multiple variations of this. Every patient is different. This was a combination of multiple patients, and the justification for everything is based specifically on each individual patient and what's in their medical record. So case number 2 is traumatic brain injury. This was a severe brain injury, although I feel that the patient healed to a point where he's now moderately impaired compared to catastrophically impaired. So Mr. Jones is a 31-year-old male. He was married at the time of the accident, but is now separated from his wife. He has 1 daughter who he has not seen since the separation from his wife, and he lives with his parents and brother. He is a U.S. citizen and speaks English and Spanish, but his family speaks only Spanish. He's a former smoker, but has quit as of the accident, and he has a history of recreational drug use, but there is no use at present. He left school in the 10th grade to work, and he later obtained his GED. Prior to the accident, he worked as a foreman doing scaffolding work, and post-injury, he's now disabled. So this patient, Mr. Jones, we'll call him, was involved in a motor vehicle accident when his motorcycle collided with a truck, resulting in a TBI. At the scene of the accident, he was unresponsive with abnormal cerebellar function. He had a discontinent gaze, but his pupils were reactive. He was transported to a trauma center where his head CT revealed a 4 millimeter subdural hemorrhage with associated 6 millimeter left to right midline shift with a superimposed diffuse subarachnoid hemorrhage with minimal herniation on the left, with mild effacement of the basal cisterns and tonsillar herniation to the C1 vertebral level with likely compression of the brainstem. He was taken immediately to the operating room for a placement of an ICP monitor and drain. Post-op CAT scan of the brain still showed worsening of the subarachnoid bleed, with some areas of new bleed noted. In addition, his left pupil was noted to be slightly large and more sluggish than the right. He was spontaneously moving his right upper extremity, but nothing else, and it was unclear if his movements were purposeful or not. His neurological exams improved significantly over the course of his hospitalization. So as you can imagine, he was intubated, and he was kept in a medically induced coma for a significant period of time, and then he was gradually awakened as the swelling went down and as the bleeding stopped. His neurological exam improved significantly over the course of his hospitalization, and he was eventually able to follow commands and have a full coherent conversation. His mental status improved dramatically to the point where he was fully awake and alert and oriented, but had difficulty remembering the name of the hospital. He was able to speak at times, but had memory loss and word searching problems. Neuropsychological testing revealed impaired verbal learning, naming, and processing speed, relative weaknesses in verbal recall, attention, and fine motor dexterity when using his right hand. He had ongoing issues with memory, attention, concentration, organization and planning, word finding, and he manifested slow processing. He would forget the content of conversations and had difficulty focusing. Reading was difficult, and he often didn't understand what he was reading, and things were taking much longer due to processing problems. At the time of my evaluation, he continued to report the above problems, and he manifested this in the evaluation. He got the date and time of our meeting wrong twice, even with reminders. During conversations, he would repeatedly forget what the question was. He had poor follow-through, even with using all the compensatory techniques that he had learned. When answering a question, he would confabulate and then never really answer the question. His responses were really lengthy, and he wasn't able to find the right words to describe what he wanted to say. Now, this evaluation was done by Zoom. And about 30 minutes into the evaluation, he reported dizziness. And he said that occurs when he's concentrating too much. He says computer work is also a trigger for him. If he does that, his vision blurs, and he says it feels like things are moving and he's losing his balance even though he's sitting. He states his comment was he needs to get more oxygen, is what he thought. He stated when this type of thing occurs, the voice of whoever is talking sounds distant and then broken up. His eyes get blurry and he can see spots. The event starts with pain on the top of his head that is pulsating, throbbing pain, and it goes faster and faster if he doesn't stop and rest. He will rest for a while and then it will go away. He also has bilateral shakes or tremors of his hands, the left greater than right, but it does occur bilaterally. With reading, he has pain in his eyes if he reads too much, and he cannot remember what he has read. When he reads, he doesn't understand all the words, and he can't remember how to process them. Pronounce them, sorry. Reading is too difficult, so he avoids this now. He states when he went to get his GED, he states that he got dizzy and then fainted and ended up in the hospital. In regards to functional mobility, Mr. Jones was very impaired post-acute hospitalization and spent a lengthy period of time in rehab. By discharge, he was independent with regards to basic activities of daily living. He ambulates with a notable limp on his right foot and a foot drop on the right. He no longer uses an assistive device, constantly, but does wear an AFO to prevent foot drop. In his evaluation, he did continue to complain about problems with ambulation. He uses a loft strand crutch in his left hand intermittently. He reports pain in his elbow and wonders if it's from the crutch use. He is using an AFO on his right lower extremity, as he states he's unable to plantar and dorsiflex his ankle. Both lower extremities are weak, and he states that his leg is very sensitive and jerks uncontrollably if someone or something touches it. On his right leg, he has pain in the muscles and the outer aspect of the ankle. He states he forgets he is injured, then goes and does something. He forgets to protect himself and then remembers after when the pain starts. He's unable to carry anything without increasing the pain in his legs. He states it feels like his bones are moving and they feel like they will break off. If he does too much, he can only stand for 10 to 15 minutes before the pain starts. He has constant pain on the bottom of both feet. He's tried gel inserts and even tried them in his AFO, but he found the pain increased and his gait was more irregular. He only wears 2 different pairs of shoes now because of this problem. He states he's able to sit with no problem, but he's not pain-free. The pain continues when he's sedentary. Mr. Jones reports that he can now do stairs, but he can't do them many times due to fatigue. He's unable to run and states that he tried to go faster with activities, but it felt when he did that his leg was going to pop apart or break. He takes no medication for pain. He is independent with all ADLs, and he uses a shower chair due to fatigue in the shower. So he's independent with bathing, dressing, and putting on his own brace, socks, and shoes. In regards to IADLs, he states that he has started shopping. However, he needs to be driven. And once he's at the store, he uses a store scooter with a basket and is only able to do his shopping sitting down. And what he can carry is just what can be in the basket in the scooter. When he gets home, he can carry a small bag, but nothing that weighs anything significant. And he opined that he thought it was about 30 pounds. But he can't walk with it for a long time because it causes pain, severe pain. In regards to cooking, he's been restricted by his family from cooking due to potential safety issues as he walks away and forgets what he's doing and burns things. In regards to management of the home, he does little to assist. His parents' yard is 60 feet by 100 feet, and he states that he has mowed part of it for his parents a few times. He can cut branches when they need it, and he can sweep. He's unable to shovel due to right hand fatigue and right foot drop, as well as left leg problems. Mr. Jones is presently not medically cleared to drive due to his head injuries and seizure activity. He has an interest in driving again, is interested in trying a driving test in the future. Hand controls would be an option and plan for the future in the event that he is cleared medically. So Mr. Jones sustained a significant TBI at the time of his injury. EEG showed that he was having seizures, which ultimately improved with Versed, drips, and Keppra. He was continued on Keppra, but with no further seizures for a few years. This was later discontinued. However, once he was healed, Mr. Jones attempted to complete his GED test, as we talked about before, and this was very difficult for him. Following the test, he had gone to the hospital and he was very agitated. Then he said he went to bed shortly after, and during the night that night, he had a tonic-clonic seizure. He was treated in the hospital and then put back on Keppra twice a day. He continues to be seen by neurology for his seizures and chronic post-traumatic headaches. He remains on anticonvulsant medication and is currently on Keppra and Depakote to manage his seizures. He has episodes of breakthrough seizures due to noncompliance with his medication and behavior issues. His family oversees his medication and gives it to him. His post-traumatic headaches were treated with Adjuvi injections, but he no longer requires that, and he now uses Advil only. He continues to live with his parents and his brother. His parents are supportive and frequently attend his appointments with him. However, they do not speak English, and so translation services are used at the time of the appointment. His parents oversee his medications to ensure compliance. His mother does the grocery shopping, food preparation, and cooking, and cleaning of the house, and all his laundry. He has developed psychological issues and developed paranoid behavior. He was having agitation and hallucinations, and these resolved with changes in meds, but he then transitioned into anxiety and depression and is treating with a psychologist. So let's go on to the next slide. So these are, obviously this was a very significant injury and he had multiple body parts affected. So we're talking about his brain injury, but you have to remember that there's often other things that are happening, including, let's see, he had this, people have rib fractures, fractures in multiple body parts. He had a left mastoid fracture. He had a left ICA dissection. He had a C-spine ligament injury. He had rib fractures and sternal fracture. He had liver lacerations with associated hemorrhage and a hemoperitoneum at the time of the injury. He had a open left tibial fracture with external fixation, and then a distal right femur fracture with external fixation. And then he had a right femoral artery injury, a right lower extremity compartment syndrome, and a compartment syndrome of the medial left thigh. He also developed dysautonomia, and he also developed infections. If you could go on to the next slide. So this guy's had a lot of things happen. These are all the secondary diagnoses that occurred with it, which I won't go over. And if you can read them through later, but the underlying issue, the big point I want to get across here is that every patient's different. They have multiple things that are happening to them. So one brain injury is not another brain injury. So here you see all the actual injuries that he had. So his lower extremities, his extremities were very impaired. He had a fasciotomy bilaterally, and he ended up having to have hardware removed because of an infection and new stuff put in. So, he went through a lot. Next, please. So now let's get into the treatment recommendations. And let me get to my spot here. So it's been approximately, when I saw him, it was approximately 4 years since his traumatic brain injury. And, now we're looking at what he needs now and what he may need in the future. So he's had multiple different types of therapies for a significant period of time, but hadn't had anything recently. So since it's been 4 years since his traumatic brain injury and he received cognitive rehab treatment afterwards, his cognitive deficits are considered permanent. He remains forgetful with poor concentration and word finding difficulties, and compensatory strategies. He did not retain those. So I did put a treatment in place for him to actually participate in occupational therapy evaluation and then treatment with speech also for those cognitive problems. These are just the evaluations. The next section is going to be the actual treatment plan for the treatment. So if we could go to that, it'll be easier. So obviously, in the past screen, there was a driving evaluation. So I gave him one driving evaluation and a course of treatment for that in the event that he can drive, but it's not clear that he is going to be able to. Physical therapy has been put in also for exacerbations and complications. So he had a lot of trauma to his lower extremities and continues to have an antalgic gait, severe pain. And so exacerbations and complications are going to happen. So I put in twice a week for 12 weeks for 24 visits per exacerbation and 9 exacerbations in his lifetime. Next, so future medical treatment, he's treating with a neurologist. So he has a history of seizures, and following his injury, his seizures were treated and resolved. But a couple years later, they reappeared, and he was placed on anti-epileptic medication again. So he sees a neurologist for that, for his seizure disorder, and which are complex partial seizures and chronic post-traumatic headaches. His medications, compliance with medication has been variable due to his memory issues and lack of ability to manage his medication, and his mother helps him with that. So continued visits with a specialist intensely are recommended to help get better control of everything for 2 more years. And then from 34 to his lifetime, neurology will remain following him twice a year. For exacerbations and complications, he's at risk for these. And so for any problems that come up, 2 visits per exacerbation were put in for the neurologist in the event that he has a breakthrough seizure or some other problem. Ophthalmology is another area. He has vision issues. He recalls wearing glasses as a child to read, but he hadn't worn them in at least 10 years prior to this injury. These complaints have not been investigated and evaluation. So these complaints have not yet been investigated, and an evaluation and follow-up with an ophthalmologist is recommended to evaluate for any changes and recommend treatment twice a year for 2 years, and then once a year after that, because these could be vision changes that happen from the injury, actual structural changes versus just brain injury issues. As far as orthopedic management, again, he had multiple complications of his bilateral lower extremities with still non-healing wounds. So from his present age to lifetime exacerbations, visits with the orthopedic was put in place. So 3 visits per exacerbation in his lifetime to coincide with the therapy that he's potentially going to be receiving when these problems bother him so much that he can't function or his functional level changes. His primary care physician is going to be his gatekeeper regarding any of these treatments and for him to be able to go to the specialist. So his primary care physician will be seeing him 3 times a year, in addition to his regular wellness visits. Let's see, I think we've addressed all of these. Psychiatry has been put in place for the next 2 years, 2 visits per year, to make sure that we have a good handle so that his mood is appropriate and his behaviors are appropriate. And then after that, 2 per year throughout his lifetime. With the help of his primary care physician, all the medications will probably be ordered through the primary care physician at the recommendation of the psychiatrist. And laws have really changed so that now you really are seeing people more frequently with any kind of mood-altering medication for management. Psychologically, he needs counseling to assist with coping and acceptance of his limitations and even identification of his limitations. And so I did put a course of therapy in there, which is over the next 2 years that he would do that. And then with behavior issues and exacerbations of his mood, it's anticipated that he's going to need interventions intermittently throughout his lifetime. And so treatment was put in place for that. Diagnostics and lab work. EEGs are done because of his history of seizures, and with the resumption of his seizures and his inconsistency with medication, they'll be checking lab values, and then they'll also be doing EEGs to see if what he had was actually a breakthrough seizure. So those are anticipated for any complications, 1 per exacerbation, 9 exacerbations in his lifetime. With his lower extremity problems, X-rays and MRIs would be anticipated of either extremity, either lower extremity, and those have been identified as 1 per exacerbation. So obviously the X-ray would be done first, and then if he has ongoing and treatment plan put in place, and then if he has ongoing issues, an MRI would be completed. With the medications that he's on, and with his other trauma and bone and soft tissue injuries, I would anticipate that he would have blood work done twice a year with his Depakote level to evaluate to make sure that he's staying within therapeutic range. He would also have a metabolic panel with electrolytes, including a liver panel, just because this puts him at risk for organ toxicity, and so they'll want to watch his levels. When he had his neuropsych evaluation, he was having problems with sleep, and with there being an added risk for sleep problems with TBI, the neuropsychologist recommended a sleep study, and it didn't look like it was done, so I put 1 in his plan. And then he had a CTA of the head and neck, which showed persistent left cervical interior internal carotid artery dissection extending into the cavernous segment. So a left cervical ICA pseudoaneurysm and a left cervical ICA narrowing in the region of the pseudoaneurysm. So they recommended a repeat CTA to evaluate for any changes and he did not remember that it had been done and it was not in the medical record. So one was additional was put in the plan. And then obviously, if he has any cognitive changes or mental status changes, repeat MRIs of the brain would be recommended with his significant injury. Next. And then durable medical equipment. So he's very ambulatory. I mean, you have traumatic brain injury patients who have problems for their entire lifetime, where they're bedridden or lifts to the chair with a significant impairment in quadriplegia. Thank goodness he recovered significantly. He still has functional problems, so I would put things in place to help prevent further injury, which would be a fully electric bed. In the shower, grab bars, handheld shower head, shower chair. DME of that type is usually every 5 years. In addition, he has problems with remembering his medications, and one way to assist him in training himself to go and get his medications would be a hero machine, which would be purchased, and then a program or a cost yearly for the program. And so this can be pre-filled for a month in advance. It lights up and is vocal about taking medication to remind the patient, and that would be a great option for him. His parents are helping him with that, but to attain the greatest independence, that would be recommended. He's also using Lofstrand crutches, which is one every 5 years, and those will be kept in place. In addition, he cannot ambulate long distances because of the damage to his legs and his pain status. So a scooter is recommended, as well as a scooter lift trailer every 5 to 10 years. Usually their scooters are replaced every 5 years, so 4 per lifetime. And also, you know, he is walking with crutches right now, but he may need a walker in the future. So that is provided for days when he's feeling exceptionally bad. And that's it for durable medical equipment. Medications are based on what he's on right now at the time I'm doing the life care plan. So 1 prescription per month at a base cost, and that is it for his lifetime. Next. And then home care services. So as far as case management services, those were recommended as he has a poor memory as a result of his injury. His treatment has been fragmented as he missed appointments and doesn't follow through with recommendations due to forgetfulness. So case management services to coordinate and facilitate treatment recommendations, and also to improve his compliance is recommended. So I did include 4 hours per month. That includes travel time. He is unable to, this is a first option. So he's living at home with his family, with his mother and father. Normally children would hopefully start doing stuff for their parents sooner than age 50, but at least by age 50, it's anticipated that his parents are between 70 and 80 years old, and he would be taking over lawn mowing. So as he's staying in the home, and that would have been his responsibility, I did put lawn mowing once a week for 6 months out of the year, starting at age 50. In addition, the same for snow removal. And then a skilled nursing visit, an RN or an LPN monthly to fill the hero. And then we have to assist with AM and PM care as his mother ages and isn't able to help. So she'll be like 75 when he turns 50. So that is to allow help in the morning for bathing and dressing, and helping to get him ready for bed at night. And that is from 50 to 60, and then from 60 to 70, 6 hours per day. And then from 70 to 76, his life expectancy, 8 hours per day. It's anticipated that obviously his parents will be long gone and he'll be by himself at that time. So he'll need help with transportation. He'll need help with setting up appointments. He'll need help with going grocery shopping and doing his laundry and work around the house, like cleaning. So a home health aide will help with all of that. And then there's spring and fall yard cleanup to do all the heavy stuff around the house when he has aged out. Orthotics and prosthetics, he's using a unilateral AFO right now, and so those are replaced every 2 years. And then uses custom orthotics in addition to this, and those would be replaced every 2 years also. So that is what he needs for orthotics and prosthetics. Next. So transportation is still a little bit of a gray area because it would be great if he cognitively improved enough that he was able to use the car. And so until the testing is done, we don't know. We don't have any indication. So I did include vehicle hand controls with installation in the event that he can drive locally, at least, to go to the bank or get his mail or go to the grocery store at the corner. But for anything where he has to go any distance, an Uber or a Lyft was identified and costed out. So he has a weakness in his right foot that compromises his ability to use his right leg for any length of time when driving. So he'd use hand controls, and he'd need transportation for shopping, therapy, physicians, appointments, and visits with friends. So from present age to age 49, 2 to 3 trips per week for groceries, errands, visit with friends, and treatment appointments, 25 miles total each appointment. There's 214 trips for appointment outlined to age 49 for medical trips. And it would be 1,144 trips per week, 1 trip per week for visiting, errands, groceries, totaling 1,358 trips. And that is the cost of a Lyft ride or an Uber ride for that distance. And then, so oftentimes when you see a patient, there are so many options that can happen to that patient, or because we don't have crystal balls, we don't know what they're going to do. So we don't know if they're going to stay in the home. We don't know if they're going to end up staying in the home part of the time and then going to a facility, or whether they're going to need a residential home. There's all kinds of things and options available to patient. So what I often do is put in 2 or 3 options or potential life care plans with the different variables in them. So the first option was for him living at home with his parents until they were no longer available. And then the second option is his living at home. If you could go on to the next screen. Living at home, but if he doesn't have family support or something was to happen to his parents, then an assisted living facility may be indicated to provide supervision, assistance with ADL, socialization, and transportation to some medical appointments. If you could go to the next slide. And so assisted living costs were put in place from age 50 in this option to his life expectancy. Now, there were other tables that got affected by the fact that he's going into assisted living that I didn't put in the screen, just because could be it's a huge plan. So obviously there would be changes to transportation and changes to DME. Everything else would basically stay the same, but those things would change. So in the plan, I usually identify the different tables that have changed because of the change in the plan. And then that summary total is completed to show you what the difference in cost between living at home with home care as we outlined, and then living in a facility from age 50. If his behaviors got really bad, he could end up having to go into a residential home for patients with TBI with behavioral issues. And then there's a whole different type of plan that can happen because of that. So again, these are always evolving plans because people change and things happen. And so we always reserve the right to update the plan as we get more information or the patient's condition changes. So this is just a snapshot of 2 very different head injuries, and there's millions more. I hope this has helped you identify what you think needs to happen in a plan, and please feel free to reach out with any questions or concerns that you have about the plan. I'm always happy to answer questions.
Thank you, Cindy, so much. I know that our viewers will really value the case studies and seeing the variances between a mild concussion to a catastrophic injury, and how, as you said a few times, every patient is different. So with that, we'll draw this webinar to a close. Please remember that our consultations at MLCC are always complimentary, and we provide comprehensive life care plans. So you've seen a snippet of some of these here today. Life care plan projections and medical cost projections, medical chart reviews and chronologies, Medicare set-aside allocations, focused estimates of care, and legal nurse consulting services. If you also have completed this webinar, please take a moment to scan the QR code and you'll find 3 pounds of matter as a session that you can survey. Again, thank you for listening, and we hope to work with you soon.